All right, everyone, welcome. Let's dive right into one of the biggest challenges we face in the OR. I'm talking about managing the chronic pain patient through a surgical procedure. It is so much more than just our technical skill, isn't it? It's about really understanding a nervous system that has been completely rewired. It's about navigating some incredibly complex pharmacology, and, maybe most importantly, truly appreciating the profound psychological weight these patients carry. So today, let's break down how to master it.
So here's our game plan. We're going to follow the patient's entire journey. We'll start by understanding their unique physiology, get into the weeds on pharmacology, and then walk step by step through preoperative planning, our intraoperative techniques, and finally, how to ensure a safe postoperative transition.
Okay, first things first. Before we can even begin to talk about a management plan, we have to grasp one fundamental concept. The acute pain that we treat every single day is not, I repeat, not the same thing as the chronic pain these patients live with. Getting this distinction right is the absolute bedrock of everything we're going to do.
You know, this is such a critical shift in perspective for us. We're trained to think of acute pain as a symptom, a useful signal, right? It's a warning sign protecting the body. But chronic pain? That's not just acute pain that's been going on for a long time. The entire system has been hijacked. It's undergone a fundamental, maladaptive transformation. It's no longer pain as a symptom. It's pain as its own distinct disease.
And this right here? This is the how. Central sensitization. It's the neurophysiological explanation for that disease state. You see, with persistent pain signals coming in, the dorsal horn neurons get progressively more and more excitable. That's the classic wind-up phenomenon. But it's even deeper than that. It actually involves transcription-dependent plasticity, meaning the very genes that code for receptors and ion channels are changed, locking the central nervous system into this state of hyperexcitability. And that is why these patients have such a massive, amplified response to the new stimulus of surgery.
Now, think about what this quote is really telling us. It's giving us a core strategic principle. If that constant peripheral buzz is what's keeping the central nervous system on high alert, then what happens if we block it? Well, regional anesthesia suddenly becomes more than just pain relief. It becomes a direct countermeasure to the underlying disease process itself. It's a powerful mechanism-based weapon in our arsenal.
But here's the thing. The pathology isn't just biological. We will fail these patients if we only target their nerves and receptors. We have to embrace the biopsychosocial model. It forces us to see that a patient's anxiety, their fears, their family situation, these aren't just side effects of the pain. They are active, powerful drivers that are perpetuating the disease.
I absolutely love this orchestra metaphor because it's just so perfect. Think about it. The biology, the central sensitization, the tissue damage, that's your strings section. But the psychology and the social factors, that's the powerful brass and the booming percussion. Now, if you, as the conductor, only pay attention to the strings with, say, a nerve block, what do you get? You get a terrible noise. A successful outcome, a real rehabilitation, requires a multidisciplinary inductor to harmonize the entire performance.
All right, so now that we have a better picture of the patient, let's turn to our tools. It's time to open up the pharmacological toolkit, and we need to have a really clear-eyed, honest view of not just what these drugs do, but what their very significant limitations are, especially in this population.
Let's start with the elephant in the room, opioids. This table really highlights the great dichotomy. For severe acute pain and cancer pain, they are, without a doubt, our most powerful analgesics, gold standard. But, and this is a huge but, when you look at chronic, non-cancer pain, the story completely flips. The meta-analyses are pretty clear. Any pain reduction is often clinically insignificant, there's no real improvement in quality of life, and all of this comes with the huge risks of tolerance and addiction. Using them as a sole therapy in this setting, well, the evidence just isn't there.
Next up, NSAIDs. With these, it's a classic risk-benefit calculation, a constant trade-off. Sure, they can be great for inflammatory pain, but the non-selective agents put the GI tract and kidneys at risk. And the COX-2 selective agents? They might spare the gut, but they can increase cardiovascular risk. And, super important to remember, they really don't have a role in neuropathic pain.
Now this is where things get really interesting. We have these two classes of drugs, antidepressants and antiepileptics, that we've essentially borrowed from other specialties, and they've become absolute cornerstones for treating neuropathic pain. Why? Because they get right to the heart of the pathophysiology. They work by stabilizing those hyperexcitable neurons. Of course, the trade-off is often those significant CNS side effects, sedation, dizziness, cognitive fog.
So we've covered the pills. Now, what about the procedures, the needles, the blocks? I want to talk about this because there has been a huge, radical shift in how we think about their role. We are no longer chasing a cure with a needle. Instead, we're using these procedures as strategic tools to facilitate rehabilitation.
So let's dive deeper and critically evaluate some of these common interventions. The guiding principle has totally changed. We don't see them as standalone cures anymore. The new goal is to use an intervention to create a temporary window of opportunity, a period of reduced pain that is just enough for the patient to engage in the active therapies, like physical therapy, that produce real long-term functional improvement.
Let's be really honest with ourselves as we look at the evidence on this table. The contrast is stark. For cancer pain, sure, techniques like neurolysis have a well-established role. But for chronic non-cancer pain, the evidence is, well, it's shaky at best. Neuroablation can actually cause a worse type of pain. Long-term steroids show no real benefit. And even the advanced therapies like spinal cord stimulators still lack validation from large, blinded, randomized controlled trials.
And this quote, this is so incredibly important. It gets at a real danger in our practice: iatrogenic medicalization. Are we, with the best of intentions, accidentally making things worse? By offering block after block for just short-term relief without a bigger plan, we risk reinforcing this idea that the patient is broken and that the only solution is a passive one delivered by a doctor with a needle. We can undermine their own role in recovery.
Okay. Now we get to the real heart of the matter for us as anesthesiologists, the preoperative assessment and planning. I cannot overstate this. Everything we've talked about so far leads to this moment. Success or failure in the postoperative period is so often decided right here, before the patient even rolls into our operating room.
This shouldn't be a suggestion. This should be your standard operating procedure, a non-negotiable checklist. Step 1. Get the full story on their pain. You need to know their baseline inside and out. Step 2. Get that med list. And I mean everything. Over-the-counters, supplements, you name it. They often forget to mention things. Step 3. You have to screen for the psychosocial factors. Catastrophizing, for example, is a huge predictor of poor outcomes. And Step 4, which might be the most crucial, you have to educate them. Set realistic goals. The goal isn't zero pain. The goal is manageable pain that allows for them to get up and recover.
This slide is everything. We absolutely have to get these terms right, not just for ourselves, but for how we communicate with our surgical colleagues, with nurses, with everyone on the team. Physical dependence, tolerance, addiction, they are three different things. Dependence is a normal physiological adaptation. Our job is to prevent withdrawal. Tolerance is why these patients will need 2, 3, even 4 times the normal opioid dose post-op, and we have to anticipate that. Addiction is a separate behavioral disease. Conflating these terms stigmatizes patients and leads to undertreated pain.
All right, we've done all our homework. The patient is on the table. What now? What is our intraoperative game plan? The key words here are individualized, preemptive, and multimodal. We need to attack the pain from every possible angle. I want you to think about this as having 2 jobs at the same time. Job number 1, do not let the patient go into withdrawal. This is non-negotiable. You have to maintain their baseline regimen of opioids and adjuvants. Job number 2, aggressively treat the brand new superimposed acute surgical pain. And this means embracing multimodal analgesia and being prepared to use opioid doses that might seem shockingly high for a normal patient, but are absolutely necessary for someone with tolerance.
So when it comes to the anesthetic itself, honestly, the specific general anesthetic agent you choose is less critical. But this choice right here, the decision to incorporate regional anesthesia, this is a huge deal. This is a potential game changer. You are directly blocking that peripheral input that fuels central sensitization. It provides better pain relief and can drastically cut down on how many systemic opioids they're going to need.
Let's talk PCA strategy. For an opioid-tolerant patient, the background or basal infusion is not an optional add-on. It is absolutely essential. That basal rate is covering their baseline. It's what's preventing withdrawal. The bolus dose, the button they push, that's for the new surgical pain that's later on top. A really good starting point is to make the bolus dose equal to the hourly background rate, and then you have to assess and titrate aggressively from there based on their use.
And please remember, our job is not done when the surgery is over. In many ways, one of the most high-risk periods is just beginning.
The transition from acute surgical pain management back to their chronic pain regimen demands a very clear, very structured plan.
So here's a practical timeline that can provide a safe pathway. The first 24 to 48 hours are all about aggressive control of that acute pain. Then, once things stabilize, you can begin a gradual taper of the acute opioids, maybe 20 to 30% a day. As soon as you can, convert back to oral medications using proper equianalgesic calculations. And one critical pearl: if you're reapplying a fentanyl patch, you must remember to bridge that 12 to 16-hour gap to therapeutic effect with short-acting agents.
And this brings us right back, full circle, back to the orchestra. It proves why we simply cannot achieve the best outcomes on our own. It is just not possible. We, as anesthesiologists, might conduct the perioperative biomedical plan, but the psychologist, the physical therapist, the occupational therapist, they are all absolutely essential players on the team. Real success depends entirely on the coordinated expertise of everyone involved.
So I want to leave you with this final thought, which I think perfectly captures our evolving role. Yes, we are technical experts with procedures and pharmacology, but for these patients, that is often not enough. Our most powerful abilities might just be those of an educator, a coach, and a motivator. We have to use our white coat credibility not just to prescribe and inject, but to validate the reality of their pain while also guiding them toward active rehabilitation. This dual role, well, it's the very essence of modern, effective pain management. Thank you.